Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health, answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle, and I'm here to answer your questions to the best of my ability.
Our first question for you today, Dr. Mingle, comes from Danielle. And Danielle asks, how does CMS know if a patient and payment is attributed to the ACO?
Great question, Danielle. 3 processes converge to create that link. First is billing. Billing firmly connects a visit, a date, a patient, one or more services or CPT codes or HCPCS codes, depending on where you're looking for those. One or more diagnoses, that is ICD-10 codes. A provider, that's an NPI. A practice, that's a TIN, TIN, and payment. All those elements are permanently connected to a bill. The second factor is ACO formation. When the ACO forms, it recruits practices and providers and provides CMS with a list of participating providers, that is TIN NPIs, that it updates as that list changes. And Medicare tracks it. You can see the tracking in the QPP status tool. Finally, attribution is the third element. CMS has a frequently updated process that attributes patients to ACOs. It can be a little different from ACO to ACO. It differs over time, so when the ACO is formed, might create some differences. And that attribution of patients to ACO is typically not complete until the performance year is over. And that attribution process links patients to providers. By linking that patient to providers, it links the patient to practices. And by linking the patient to practices, it links it to the ACO. So that all those things together means by defining the ACO by TIN NPIs and understanding billing from the billing process, that process allows CMS by the end of the year or shortly thereafter to attribute patients and payments to ACOs. I hope that answers your question, Danielle. Thanks.
Yeah, thank you, Danielle. And Danielle had another question for you today, Dr. Mingle. So her second question is, when participating in an ACO, are billable charges different than the standard fee schedule?
Oh, great. Another great question, Danielle. Until now, they have been the same, and including now, that is the same, but that will change soon. The Quality Payment Program began with an incentive payment for qualified participants paid in a lump sum the year after the qualified participation. It amounted initially to 5% of payments based on the standard physician fee schedule. For the 2025 payment year, it will be 3.5% of payments based on the standard physician fee schedule. Starting with the 2026 payment year, qualified participants in advanced APMs, that is APMs that have both an upsided gain and a downsided loss in their contracts with Medicare, will be paid more for each service than everyone else is. Payments for QPs, that is qualified participants, will still be calculated from the same fee schedule with the same RVU amounts attached to the codes and the same geographic modifiers that everyone else uses. But for QPs, there will be a slightly higher conversion factor, that is a higher allowable charge for each service code that is applied relative to the qualified participants. So I hope that answers the question, makes things clear for you. Thanks for the questions, Danielle.
Yeah, thank you, Danielle. And our next question for you today, Dr. Mingle, is from Tim. And Tim asks, How will our providers get credit for promoting interoperability? And then he adds some context. We are a group practice using a certified EHR. Part of our practice is service of patients in extended care facilities. We were recently recruited by an ACO that is specializing in care in extended care facilities. For their model, our ECF providers have joined their extended care facility practice and bill their ECF work through that dedicated practice 10. For our group practice, we submit promoting interoperability for MIPS. Will our MPIs in the ECF 10 get the home 10 score for PI in the ACO?
Great question, Tim. Kind of a special case that won't apply to a lot of you out there. For those who do and for similar situations, the answer is no. Medicare does not recognize the concept of NPI, that is not, at least not NPI alone, in the QPP program. Individual providers, in the eyes of the CMS QPP, are 10 NPIs. So an NPI is a different entity to CMS and the QP in each 10 that the NPI participates in, each tax ID number, that is. So the PI score developed in one 10 does not apply to the NPI in another 10. The provider is a separate entity in the eyes of CMS QPP in each 10 in which they bill. So the PI submission you make for your group will not count toward the work your provider does in the ACO eCF 10. That's the Accountable Care Organization, Extended Care Facility, Tax ID number. That is a unique business, and the NPI, the physician or provider, becomes a unique entity in that 10. The better news is, so long as the ACO eCF 10 exclusively works in facilities, those providers have a valid exception to the need for a PI submission. They're even accepted from the progressing rules requiring ACO participants to use certified EHR technology or CERT. Your providers don't, in fact, need to be exclusively in that ACO 10 working in extended care facilities. As long as at least 75% of their volume is in ECFs, it qualifies them for that facility-based exception. And it doesn't have to be the same ECF or even the same type of facility. Each 10 NPI who generates at least 75% of billing in any combination of facility, that includes extended care facilities, hospitals, or ambulatory surgical centers, should qualify for the exception. And the 10, so long as at least 75% of the 10 NPIs qualify for the exception, the 10 will qualify as a group for that facility-based exception. Now, Medicare should automatically identify that facility-based exception for each of the providers. And Medicare should automatically identify the facility exception for the ACO eCF 10. You can check that out on the QPP status tool available on qpp.cms.gov homepage. Status can be checked by individual NPI and by group TIN. Now, you should check your status, or the TIN they're participating in should check that status at the TIN level. If Medicare has not granted the facility-based exclusion or exception to the ACO eCF 10, you should, in the identity, or that 10 should, in the identity of the ACO eCF 10, apply for the hardship exception based on facility-based work. Well, kind of a focused question, very narrow application, but it should give you some more insight on how that exception is applied. Thanks, Tim.
And our final question for you today, Dr. Mingle, is from Leanne. And Leanne asks, what is the eCFR?
Great question, Leanne. Now, you'll hear me often refer to the eCFR. eCFR is the Electronic Code of Federal Regulations, found at www.ecfr.gov. Now, at the federal level where Medicare lives, The House and the Senate make laws, they pass legislation, which go to the president's desk for approval or veto. Nothing goes from the president's signature to enforcement directly. Each element of each legislation is managed by one of the federal agencies or departments. Those agencies interpret the legislation into a set of rules to make it work. Those rules have to be drafted. They're required to be proposed and delivered to the public for comment. The comments have to be collected, analyzed, and taken into consideration. Then a final rule is published and goes into effect shortly thereafter. All rules are continually subject to adjustment as the federal departments responsible for them learn from experience. Even in the absence of changes to the legislation, rules will be adjusted from time to time to reflect the agency's experience and to better match the legislative intent. Thus, we get an annual cycle of rulemaking for many of the rules, and particularly in this context, for the physician fee schedule and the quality payment program, which is lumped in with the physician fee schedule. Now, for the physician fee schedule and the quality payment program, we typically see a proposed rule early July every year. We typically have until early September to have reviewed that proposal and to submit comments. Then the comments are reviewed, and the proposed rule is then worked into a finalized rule and released typically November 1st. New rules go into effect usually January 1st, ready or not, and then the cycle starts over again. Now, if you've ever read the proposed and final rules, they can be tedious, especially the final rule. The text is repetitive, it's detailed, and it's often without sufficient context or definition. When the final rule is published, it is recorded in the electronic code of federal regulations, stripped of all of its redundancy and detail, and inserted into logical sequence with the specific rules that it updates. The eCFR tends to have a good organization, it tends to have a great table of contents, and it has indexing that the final rule lacks. Now, I still read the proposed and final rules. They keep Mingle right on top of the changes as they happen. But I've been enjoying, particularly recently, doing my in-depth reviews and answering questions using the eCFR as my go-to source. Once you crack the code, the eCFR becomes pretty easy to navigate. Is that it has a global organizational hierarchy that makes some sense. It has search tools that are decent. They lag a little trying to use real language, but when you're searching for a specific subject by its location in the hierarchy, it flies. Of interest to me, and probably to you, since you're listening to me, the hierarchy of most importance to us is Title 42, which means public health. Chapter 4 within Title 42, which is the Centers for Medicare and Medicaid Services. Subchapter B under Chapter 4, which is Medicare. Part 414 under Subchapter B, which is the payment for Part B services. And Subpart O under Part 414, which is the merit-based incentive payment system and alternative payment models, that is the quality payment program or QPP. That last Subpart O, has a decent table of contents. Now, the eCFR is the official home of Medicare rules. It's the gold standard or the single source of truth. As Medicare updates the rules, they will collect the current rules in a variety of public-facing ways, including webinars, slide decks, frequently asked questions, getting started guides, and others. You'll find a lot of these documents and sources accessible through the Quality Payment Program, the qpp.cms.gov website. Inevitably, you'll occasionally find disagreement between the rules and the public-facing content that they spawned. In such cases, the rules are the source of truth. Most often, I see Medicare honoring both sides of that, the truth and its error, until it corrects the public-facing content to match the rules. Sometimes those epiphanies lead to an adjustment of the rules. but always in the context of annual rulemaking. They might update those public-facing guides immediately when they see an error, but the rulemaking is always adjusted in the context of that rulemaking cycle, going through proposed rule, comments, final rule, application. Thanks. I hope this helps understand what the eCFR is.
Yeah, thank you, Leanne, and thank you, Tim and Danielle as well for the excellent questions. And thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle. It was delightful. Thanks to all of you for all the great questions. I want to be helpful. I want to be useful to you. Don't hesitate to correct or supplement my answers. Share your experiences. Ask your questions. We can be smarter together.